I'm very pleased to say that not quite 3 years ago, as Angela said, we set up Recognition Health. And this is really brought about by a group of clinicians who are cognitive experts coming together, voting with their feet, and deciding that it really was time to set up a 21st century approach to managing patients and carers who are looking after those with cognitive impairment. And that includes assessment and diagnosis, which I'm going to focus on this evening, but also the treatment, the therapy and the monitoring. And later in the evening, you're going to hear one of my colleagues talking about ongoing care and support and rehabilitation. And quite recently, we have also been involved in clinical trials. So our vision is to create a comprehensive service with the most up-to-date and innovative opportunity for our patients. So, as it's quite an eclectic audience this evening, what I'd like to do first is just to say, what is cognitive impairment? And I think there is probably some confusion about this. It isn't just memory. Memory is just one of the problems that one has with cognitive impairment, as you can see here. But it's actually a whole spectrum of problems. It's visuospatial problems, speech and language, calculation, and also quite a number of functions that affect executive performance. So that's planning, judgment, and other things. And this is one of the things that makes it so difficult for doctors when they're trying to make a diagnosis. Who does it affect? Well, it actually affects all ages. And any of those of you who've been to our clinic will have seen that I think our youngest patient is about 3, and our oldest patient is certainly over 90. And obviously, it's a slightly differential diagnosis in different age groups. And as you can see here, it can be anything from traumatic brain injury, ADHD, autism spectrum, and a variety of neurological disorders. So the big challenge, and the first challenge, is making an accurate diagnosis. And just here is really not for reading, but just to illustrate the number of different causes that people can present just with exactly the same problem. Either I've got a problem with my memory, or I've got a problem with my executive function. This evening, we're going to be focusing just on these two here. This is Alzheimer's disease and behavioural variant frontotemporal dementia. So you can probably understand that when you see your doctor, he's got all these different things going on in his head as to what could be the cause. But if we zone in on this, you can see that over the age of 65, for cognitive impairment and dementia, you can see that Alzheimer's disease is actually the most common. Vascular dementia and Lewy body disease being sort of 15 to 20%, and frontotemporal dementia is actually much less common and does affect people who are younger as well as older people. And that is divided into different types, and I think probably Professor Wisher could be talking about this later, but behavioural variant is the type that we're talking about in the terms of clinical trials. So just to avoid any confusion, dementia is just an umbrella term, and there are a number of different causes of dementia. And all dementia means, it means that you've got cognitive impairment, and then you must have 2 other domains. And most usually it's progressive, and it has an impact on activities of daily living. And as you can see here, there are lots and lots of different causes of dementia: Parkinson's disease, some of these related to alcohol, Huntington's disease, etc. So why are we so focused on making an early diagnosis? Well, one of the reasons is it excludes other causes, many of which may be treatable and which need to be diagnosed and managed immediately. It has a huge impact in terms of opening doors and providing the individual and the family with the opportunity to make decisions. It enables the patient to maintain and maximise independence for as long as possible. And it also, most importantly, which we will talk about here, it allows one to determine whether or not you may be eligible to participate in a clinical trial for the very latest sorts of treatments. And as you'll hear tonight, some of these treatments now are disease modifying, and that means they can actually alter the course of events. The second challenge is that we have all these different people who potentially are involved in the patient and the carer coming to the right place at the right time and having the right treatment and management. And as you can see here, the ones in green are actually the ones which, in fact, most often will result in patients getting themselves into the right place and time to have a diagnosis. And I cannot actually emphasize how important family, general public, media, and education are. And probably the next most important, well, not next most, but the other most important one is obviously the general practitioner. So why is it so important? Well, we're now in a position where we can start to change the trajectory of Alzheimer's disease. And I think this one is quite an important thing to just bear in mind. Alzheimer's is now the only leading cause of death that is still on the rise. And the data I'm just going to show you next is abbreviated, but it's from some data that was presented quite recently on USA statistics. And what it demonstrates is that if we can get a breakthrough by 2015 with some drug or treatment that will delay the onset of Alzheimer's disease by 5 years, the impact that will have is really significant, and you can appreciate that in the context of what Angela was saying in the introduction. But the reduction of people, or the reduction in the number of people over the age of 65 who will then have severe Alzheimer's disease, if it's put out by 5 years, will be of the order of 54% by 2020 and 82% by 2050, which is absolutely staggering, both in terms of personal suffering but also in terms of socioeconomic impact. And this is just a graph to demonstrate the same thing. And this is what will happen if we don't get a disease-modifying therapy, whereas this is what will happen if we do. And you can see it's absolutely staggering, the difference. So I'm going to digress just for 2 seconds to say, and what is Alzheimer's disease? And Professor Wishape will discuss this in much more detail. But very broadly, it's a condition where the brain starts to become atrophied or lose volume, shrink. And what tends to happen is that part of the brain that's affected first is this area here in the sort of medial part of the temporal lobe where all your memory systems are kept. And with time, it then starts to spread over the rest of the brain here and starts to affect the back of the brain. And actually, people with frontotemporal dementia, this part seems to be affected more significantly and at the beginning. And what happens is 2 abnormal proteins are laid down within the brain, and they're the proteins which stop the brain cells from working normally. And they're tau proteins and beta amyloid proteins, which Professor Wishape will go into in much more detail. But the reason I showed you that slide is really just to explain something called mild cognitive impairment. And as you know, you don't just wake up one morning with dementia. What does tend to happen is Alzheimer's disease is something that happens very gradually. And what's happening in this graph here, you can see this is time, and this is about 20 years. And very gradually, these abnormal proteins are being laid down. But for a long time, it doesn't have any effect at all on one's cognitive function. But then you reach this sort of middle area here of mild cognitive impairment, when people begin to think, actually, maybe something's not completely right. And then we sort of like, as the disease progresses further, we sort of tip down here into dementia. So this is your cognitive function on the blue line, and this is the disease progressing on the red line. What's really important about this is if we can get the right treatments now, and this is what we're doing in the clinical trials, these disease-modifying drugs, is to try to keep people as much as possible in this very just sort of like mild and just the beginning of this curve here. Mild cognitive impairment, by definition, essentially just means that cognitive decline is greater than would be expected for age and education, but does not interfere with activities of daily living. And obviously, the more we can keep people in this space here, the better they will be. But what is important is that more than 60% of people progress to dementia over 3 years. And our task is to try and make a diagnosis as quickly as we can. This is, if you like, the sort of old-fashioned way of doing this. So this is just clinical examination, and this is what your GP or a doctor can do when they've got no other tools or anything to help them, just talking to you and examining you. And you can see here that if this is where the disease starts, that's normal, and this is the area where you have dementia. During this period of mild cognitive impairment, just by talking to you and examining you, it's very difficult to make a diagnosis, other than when the symptoms are really very obvious. So nowadays what we can do is there's a number of much more sophisticated tests. So this is doing complicated neuropsychology testing, which some people here will have probably been through. This is looking at MRI imaging, where we can actually see the structure of the brain and see which areas of the brain have become atrophied or have lost volume. This green line here demonstrates even more people, so we can make the diagnosis earlier and more accurately, and that's by looking at the cerebrospinal fluid to look at the abnormal proteins. And then this line here is looking at a scan called a PET scan, an FDG PET scan, and again, that provides even more sensitivity to pick up patients when they're in this very mild phase of cognitive impairment. And then, in fact, just very, very recently, in the last few months, there's something called a PET amyloid scan, which binds specifically to the amyloid protein in the brain. And soon there will also be tau PET scans which will bind to the tau protein in the brain. And what we have to be careful of now is obviously we don't start diagnosing people before they've got any symptoms at all, but what we do want to do is we want to be able to detect people who have got mild symptoms of cognitive impairment. This is just a quick example to show you a scan of the brain, and this just demonstrates how we can measure the volume of these little areas here, which is where all the memory is kept, and the area that's affected first. And we do that by looking at that volume as a percentage of the normal brain volume. And this is just to show you, we can see now very easily whether or not the scan demonstrates a significant abnormality. And this is just a very quick picture to show you what the new amyloid imaging looks like. And the most important point on this is about 86% of patients with mild cognitive impairment with this amyloid deposition in the brain will develop clinical dementia and Alzheimer's disease over the subsequent 3 years. And this is just very quickly to show you the pattern of the brain atrophy that we see in frontotemporal dementia, which Professor Wishick will talk about later. So it's a slightly different part of the brain that's affected more prominently at the beginning. So how does early diagnosis provide opportunity? And I thought what I'd do is just include one case, and in fact you'll see a number of people later on a video which illustrate these points. But in January to May of 2013, one of our patients was sort of just noticed that he had problems with his memory. By June, the family became concerned, and his son accompanied his father to the GP. The GP was very astute and quickly became suspicious that there was evidence of mild cognitive impairment. So he's in that outlier group who just by a quick conversation with the patient was able to tell very quickly that there was something wrong. As a result of that, he was referred very promptly to the memory clinic and had various scans, including the MRI scan. And by June, a diagnosis had been made, and the family and the GP provided support. In October, we had a conference exactly the same as this, or very similar to this, in this room, and that conference was reported in the Sunday Times by one of the journalists who is here. And as a result of that, the son, who now recognised that his father had Alzheimer's disease, read that article in the Sunday Times, and he sent an email through to Professor Wishick. That email was passed on very quickly to us at Recognition Health, and within about 2 days we'd spoken to the son, and within about another week or two we'd managed to get all the clinical information, and now this gentleman is on the clinical trial, and we have an opportunity to potentially change his outlook for the future. So this is just a nice graph to say that actually if everybody does get their act together and they focus, then all these people that we saw in that previous graph or in the previous wheel were involved in that last patient managing to get himself in the right place at the right time to be on the clinical trial. And as you can see here, it was actually the media, it was the family, it was the general public, it was an educational event, and there was all the people in the memory clinic, and in particular the GP, who picked this up and referred the patient on. So we can all make a difference, particularly if we all work together to provide a cost-effective pathway for patients. But you do have to act quickly when you have a diagnosis, and clinical research is now unlocking the answers. So it really is important to run, not walk, if you get a diagnosis.